Hello, you're all very welcome to our webinar this week. It's part of the ISAG, the Insight series with the Independent Scientific Advisory Group here broadcasting from Galway today. And we're delighted to have our guest panelists, Professor John Wenger from UCC, from the School of Chemistry, Environmental Research Institute in Cork, and also a practicing architect and assistant professor in School of Architecture, Policy, Environment and Planning at UCD, Professor Orla Hegarty as well. So today we've decided to look at the idea of an inconvenient truth, the role of aerosol transmission and ventilation in the spread of COVID-19, looking at the analysis, but also, very importantly, also looking at some solutions for that as well. The webinar aims to explore all of these different discussions and debates that have been going on around the question of aerosol spread and ventilation in relation to COVID-19 since February and March this year in Ireland in particular, and also looking at some possible solutions that different sectors and policymakers could and possibly should explore in mapping out future strategies to aid the active suppression of the virus in both community contexts and also in workplace settings. We're going to start today's session with Professor John Wenger, who's a specialist in aerosols and is also one of the 239 signatories of a July letter to the WHO warning about the dangers of airborne transmission of COVID-19. John is going to start the ball rolling with us today for the first 15 minutes. Then we'll move on to Orla's presentation on the role of ventilation, and then we'll open up the floor then for discussion afterwards with all of the participants as well. We're delighted to say we had over 96 people register for the event today, so we're delighted to welcome you all. And we'd like to direct your questions and comments to the question and answer function on Zoom as well. So at the bottom of your screen, there's a Q&A function, and you can pop your questions in there, and we'll get to as many of those as we can once we open up the session after the presentations. So John, I'll pass it over to you for your session.
Thank you very much, Nessa. Hello, everybody. Thanks for joining us today. I hope you find it useful, informative. It's a double act, really. Myself and Orla, we're going to talk about the aerosol transmission route and then also ventilation. So I'll just get my slideshow going, if I may. Okay, so today we're going to talk about the role of aerosol transmission in the spread of COVID-19. I work in UCC at the Centre for Research into Atmospheric Chemistry. Contact details here, okay, and also we're on Twitter as well. Our Centre for Research into Atmospheric Chemistry is really focused on understanding atmospheric composition and its influence on climate, air quality and health. And we do a range of research programs looking at laboratory simulations of atmospheric processes, development of atmospheric measurement techniques, and also field measurements of atmospheric composition. And the key thing really is that a lot of our research is actually focused on aerosols. So aerosols in the air that can affect air quality and climate and health. Just a small bit then about atmospheric aerosols, since that's my main area of expertise. Basically, an aerosol is a liquid or a solid particle that's suspended in air. And in the atmosphere, we see a wide range of particle sizes and also different particle types. So here is a little graph which shows the size scale that they're on, and you'll see that the units are micrometers. A micrometer is a millionth of a meter, and aerosols really in the atmosphere are smaller than about 100 micrometers, which is 0.1 millimeter. So they're barely visible, okay? So these pollen particles, for example, are something like about anywhere between about 10 and 50 micrometers. They're not really visible, but we know they're in the air. As we go below particles about 10 micrometers, sorry, then these can start to be inhaled into the body. So PM10, as they're called, are particles less than 10 micrometers. Around about this size range, we get things like dust and sea salt. And then we go into smaller particle ranges, smaller than 2.5, that are shown here. Things like soot and so on, that can really now be breathed in quite deeply into the lungs and affect health quite severely in some cases. So that's just a little overview of atmospheric aerosols. Today, I'm going to talk about COVID-19 and the virus that causes that, which is SARS-CoV-2. I'm going to talk about aerosols, droplets, and the World Health Organization. I'm going to then cover some technical details, I suppose, on the physical basis for aerosol transmission. Then some observational evidence for aerosol transmission of the virus, and some solutions to reduce aerosol transmission in the indoor environment, although Orla will probably pick up a bit more on that aspect. Just to acknowledge some of the resources that I've used here. I've used a lot of resources from Alex Hoffman's page, which is freely available on the web. Okay, it's a range of articles, videos, interviews, general articles. It's an amazing resource if you ever want to find out any more details about COVID-19 and the way it's transmitted. I've also picked up various bits of information from Twitter as well, and the main protagonists here really are Jose Jimenez, Lindsay Marr, Shelley Miller, and along with other scientists, they've teamed up really to provide another amazing resource, which is an FAQ on aerosols. So this really deals with a lot of the issues and questions that people generally have. So I'd encourage you to look at those resources if you're interested. Just want to start really by talking about the way that the virus is transmitted. And there are four ways that is believed to be important. The first is direct contact. So that is obviously physically touching somebody that can be infected. The second is indirect contact. And so this is where the virus is spread from one person to another, but through a surface or an object. And this is called the fomite route. These things on the ball here are fomites, and they're basically objects contaminated with the virus. And the idea then is that the person could touch that and then put their hand to the nose or mouth, and the virus could get into the body through that route. Probably the major route that was initially assigned by WHO is the droplet route, and this really is from larger particles that are emitted when people talk or cough or sneeze. And these larger particles are so large that they fall out of the air quite short range, so maybe within 1 or 2 meters, hence the distancing guidelines that you're very familiar with. They're like ballistic projectiles, and they kind of impact on the eyes or the nose or the mouth, and these are only really believed to be happening at short range. And the final route is the aerosol route, which really involves smaller particles that are emitted from an infected person through talking and even breathing. These smaller particles now don't fall out. They actually linger in the air, and they infect by inhalation, so you can breathe them in. They obviously interact at short range, but also long range, and hence that's why it's often called airborne transmission pathway. Going back to the start of the pandemic, the WHO really had it in its mind that the droplet routes, or the droplet and contact routes, were really the dominant pathways for spreading the virus. And really, just to clarify things here, on the 29th of March in their scientific brief, they clarified what is a droplet. And a droplet is a particle that is bigger than 5 or 10 microns in diameter. Okay, they're called respiratory droplets. And when they are less than 5, they are referred to as droplet nuclei. There's a bit of technical detail there, but we'll come on to that in a bit later on. They also point out that droplet transmission occurs when a person is in close contact within 1 meters of someone who has respiratory symptoms. And again, coughing or sneezing, again, is mentioned very much here in the guidance. So what are droplets and aerosols? Well, there's a long-standing medical definition that droplets are greater than 5 or 10 microns in diameter, and aerosols are smaller than that. But in fact, if you start to look into the literature and dig around, you can't really find out where this comes from. It's a kind of historical definition. And in fact, there is no data to support this either theoretically or experimentally. It's really grown out of observations from the 1940s and 50s, and it's become entrenched in the way of thinking with the WHO. And in fact, as I'm going to show you, this definition of droplets and aerosols is not supported by modern aerosol physics at all. And furthermore, observations show that droplets and aerosols can both be generated as a continuum of particle sizes during numerous respiratory activities, and the behaviors are not distinct. In other words, aerosols and droplets don't behave differently. They're all a continuum. Referring to some of those measurements now, what we now know quite well is the sizes of particles that are emitted by somebody when they're breathing, speaking, coughing, and even singing. And here is a graph that shows the range of sizes that the particles are emitted at. We have here along the bottom the particle size in microns, and here is the particle number concentration. Okay, and basically what we see is that for speaking and for coughing, we have two kind of broad peaks here. All right, we have a smaller size range that is less than about 10 microns, and another size range that's a bit smaller, which is peaking around about 200 microns. This smaller size range peaks at around about 2 microns in size, and this one peaks at 200 microns in size. If we look at the number distribution, over 99% of the particles are actually in the smaller size range here when speaking. And even when coughing, which we know generates a larger number of, a high number of larger particles, we still have over 90% of the particles are less than 10 microns. Just to remind ourselves of the virus itself, well, the virus has a diameter of about 0.1 of a micron, so it's small, all right, but it's never naked, all right? It's emitted in a ball of respiratory fluid, which can vary in size from any of these size ranges here, from anything from about half a micron up to a few hundred microns, okay? And this is the form in which the virus is emitted when somebody is breathing, speaking, singing, coughing, or sneezing. One thing to note, when the virus encased in respiratory droplet leaves the body, that's at 100% relative humidity from inside the body, and it starts to evaporate really quite quickly. Within a second or so, we get rapid evaporation of the droplet, and you can see here that the droplet is shown to contain the virus, protein, and salt, other stuff that's represented in respiratory droplets. And as over time, basically, depending on the relative humidity in the room, we'll get evaporation, and a 10 micron droplet, for example, would evaporate to something like 4 microns, and we call that a droplet nucleus. If we now look at aerosol physics, and we try to calculate how long these aerosol particles can remain in the air, then here is a very well-known equation that can be used to calculate what we call the settling velocity. And so here we have a graph which shows you the diameter of particles versus the time taken to settle from a height of 1.5 meters, which is about the height of the mouth, okay? So what we can see is that as we go down in size, we get a very large increase in the time taken to settle from a height of 1.5 meters. If we take an aerosol particle of 5 microns, which is the cutoff from the medical definition of the aerosol and the droplet, what we see is that in fact that particle can last for around about 30 minutes. And particles less than 10 microns can remain in the air for many minutes too. And the main mode of emitted respiratory particles around about 2 microns can last maybe up to several hours. So the key point here is even as we go up to 30, 40, 50, 60 microns in size, these droplets do not fall out of the air. They linger in the air, they float, and they hang around. And so they have a substantial lifetime in air. They remain suspended. And this has been confirmed by measurements. Okay, this paper here looked at the airborne lifetime of small speech droplets and their potential importance for SARS-CoV-2 transmission. They measured thousands of oral fluid droplets per second being emitted when somebody was speaking, and that they measured them for 8 to 14 minutes, and they correspond to particles between about 12 to 21 microns. Okay, so normal speech droplets hang around in the air. Furthermore, if you have an airflow in the room, which is quite normal, if you have a low indoor air velocity, for example, of 5 centimeters per second, the particle can move. All right. And if you have a particle initially again at 1.5 meters in height, how long will it take to fall to the ground whilst moving in the airflow? Okay, what we can see is that we can stay in the air long enough to travel about 100 meters. That's a 5 micron droplet. If we go to a faster indoor air velocity, we can see this is 20 centimeters per second now. We can actually see that it gets carried even further. So in principle, and as we know from atmospheric aerosols as well, aerosols can be transported quite long distances, hundreds of meters and more. So what are the scientific implications of this? Well, the scientific implication really is that there is a definite need to clarify the terminology to distinguish between aerosols and droplets, and that we really should use a size threshold of 100 microns, not the historical 5 microns, because this 100 microns more effectively separates the aerodynamic behavior, ability to be inhaled, and efficacy of interventions. And so this is actually published in a recent Science letter just about 1 or 2 months ago. What are the implications for public health? For public health, well, the viruses can remain suspended in the air for many minutes to hours and can be inhaled. They can also travel more than 2 meters and accumulate in poorly ventilated air too. And so the additional measures then that we might need to employ are to move activities outdoors, to reduce occupancy of indoor spaces, to wear a mask even at distances greater than 2 meters, to ensure we have proper ventilation to dilute the virus, and if needed, to provide some supplementary filtering and air cleaning. And a lot of these things were already known from a long time ago when the Japanese government was advising people to avoid the 3 Cs, avoid closed spaces with poor ventilation, avoid crowded places with many people nearby, avoid close contact settings such as close range conversations. And if we think about it, how can we imagine the virus traveling in air as an aerosol? Then we can use smoke as an analogy. Okay, smoke is also an aerosol. And if you could imagine smoke building up in an indoor environment, in a room, then you can imagine that the virus potentially could be spread like that. You know very well, for example, that ventilation can remove smoke from a room. Ventilation could also, of course, remove the virus from the room. So that was the physical basis for it. The physics says that, really speaking, the aerosol transmission route should be very important, if not even dominant. And there has actually been some observational evidence for SARS-CoV-2 in aerosols, which confirms this. Obviously, the places that were investigated first was where the virus was most abundant. That was in hospitals. We had detection of the virus in aerosols in Wuhan, in the USA, Singapore, and most recently at a hospital in Sweden. What they found is long-distance airborne dispersal of the virus in COVID-19 wards, where actually the virus was found in filters in ventilation ducts up to 50 meters from the source. So again, it shows the highly airborne nature of this virus. Furthermore, additional studies have shown that the virus can also remain infectious in aerosols. Here's a case study that in fact showed that, where we have a nice experiment here where the virus is sampled at a distance 5 meters from the source, but we still collected this virus, and it was shown that it could remain viable by growing in cells. Okay, and this was really called the smoking gun, because this is the first time that we could demonstrate that there was infectious coronavirus in the air. Of course, the virus has really been characterized by superspreading events. And this is a transmission where one, often asymptomatic person infects many others. Commonalities of these many superspreading events are crowded places, vocalization, shouting, singing, bars, etc., insufficient ventilation, and no masks. Aerosols here are often the most obvious mode of transmission, and we've seen superspreading events in hospitals, in meat processing plants, nursing homes, gyms, schools, ships, etc. In fact, over 1,600 super spreading events have been recorded now, and you can very easily find this link on Google. A great example and well-known example is the Skagit Choir, and this was a choir rehearsal earlier in 2020, a 2.5-hour long rehearsal where there's one index case with mild symptoms infected 52 others. And when they inspected the data and did all their analysis, they really found very little evidence for fomites and droplets. And to infect so many people, really, aerosols were the most obvious explanation because the room had low ventilation. The people were in there for a long time, there was no masks, and the people were singing. And we know that singing and vocalization increases the emission of respiratory droplets. So as Nessa said earlier on, I was one of the 239 scientists who signed the open letter to the WHO. We felt that there was easy enough evidence to convince people that this was a very important transmission pathway and it should be recognized as such, that we should increase awareness for airborne spread, the need for masks, ventilation, and indoor air quality measurements. So this did put pressure on the World Health Organization and the CDC, especially the USA, who were at the time not acknowledging airborne spread of COVID. Within a few days, the WHO did respond, and they did acknowledge that aerosol transmission or the airborne route could be important under certain conditions. However, the language was kind of lukewarm and they never really committed to this, and they haven't really updated this since July. So we're still in the same place as such. Thankfully, in Ireland, there has recently been recognition of indoor spread, the importance of ventilation and crowded environments, high-risk environments for spreading the virus. There was a HICWA report 2 weeks ago, and here's a newspaper report showing that basically high occupancy and poorly ventilated spaces present an increased risk for transmission of the virus. So here we have recognition of the importance of ventilation and implicit recognition of aerosol transmission, although transmission modes were not discussed. The WHO has also recently recognized the importance of ventilation, but not acknowledged aerosol transmission. Importantly, to date, this information has not been used to update the guidance on protective measures, including ventilation. The protective measures really are, of course, ventilation through natural ventilation, opening doors and windows, mechanical ventilation to cycle the air, filter it, and put back clean air. There's also air cleaning and disinfection, for example, using UV lamps. And of course, in environments where it's difficult to have ventilation, you can also use a portable air cleaner with a HEPA filter. All of these can remove the virus from the air. One important thing just to finish up with is this. Let's refer back to the Skagit Valley choir event. The probability of infection for each person was calculated to be about 80%. There were no mitigation measures put in place, but if one was put in place, for example, increase the ventilation to 3 air changes per hour, that dropped to 50%. Or you added a HEPA filter, which provided 2 air changes per hour. That was about 50 to 60%. Or people wore masks, or people shortened the duration. You'll see that they all had an effect. If you do all of those, then you get a very big cumulative effect, and you reduce the overall infection chance down to about less than 10%. And so what's really important from this is that we need to know that it's not just one silver bullet that can protect us from the virus. It's a whole multi-layered approach. And this is best represented by this Swiss cheese model, as it's called. This is quite popular now. And really what it shows is that the layers of intervention really all add up. Whole personal responsibilities, like distancing, masks, hand hygiene, avoid touching face, avoid crowded areas. But then there's also shared responsibilities, which ventilation falls into, as well as other measures that are mentioned too. So I'll finish there. Thanks.
That's great, John. Thanks a million. I think you've kind of set up really well, I think, kind of the historical context, but also the contemporary debates and the issues that we need to kind of be more cognizant of. And I think also your point in terms of looking at all the different contexts in which this is important, both in terms from a scientific point of view and practice, but also different kinds of spaces in which the question of aerosol transmission comes to bear, I think is something we'll be touching on now with Orla's presentation. So Orla has been writing a lot and I suppose engaging a lot on this across the national airwaves and also in a few op-eds in the Irish Times as well. So I think we're delighted to have Orla here with us today to look at how what has been a public health response in many ways is now demanding a broader range of expertise. And as we keep saying, I suppose, in ISAG as well, an all of society problem demands an all of society solution. So Orla, I'll pass it over to you now.
Thank you very much, Nessa. I'm just going to share my screen. Okay. Thank you. As Nessa said, I'm an architect and I work in the School of Architecture, Planning and Environmental Policy in UCD. And you might wonder what an architect is bringing to this, but what people mightn't realise is that architects really, our job is to synthesise a lot of other disciplines. We're the people who join the dots and put a lot of complex things together to find solutions. And I think more broadly, we also have training in history and geography and building physics and engineering and environmental science and building regulation and human behavior. So all of that is very relevant, I think, to this. But we also know about ventilation in buildings and about indoor air quality, which is becoming increasingly known as a very serious issue in relation to COVID. And John has given some of the chemistry and the background to that. So that's, I suppose, what I would see as bringing to this. Just move slides. So in short, I think what we have been thinking about to date is maybe how COVID is spread through contact and droplets, and how people maybe are washing their hands and wearing protective equipment. And what we haven't really thought about so much is that we don't see the air around us. In some ways, we're swimming in murky water when we're in buildings, and we don't think of it in those terms. I think a lot of people think of ventilation in buildings as being accidental when in fact it's designed. But if you start to join the dots between cases in Ireland and cases internationally, you can start to see what's going on, and superspread is a really large part of it. John mentioned that the definition of superspread is where 5 or more people become infected at the same time. We had a recent case in Cork in September where 57 people in one restaurant were infected, and that's a very similar pattern abroad as well. And we're all becoming familiar with the sort of list of buildings where these outbreaks are happening all the time. And it's not just in one country, it's consistently in a lot of places. So it's hospitals, it's care homes, it's restaurants, schools, transport, people's own homes, and in very particular meat, poultry, fish, and sometimes in mushroom plants as well. And that is fairly common in a lot of places, and the patterns are very clear. So when we hear about statistics and data being quoted, we're often using, I think, the wrong data and looking in the wrong places for where the answers are. If you look with a knowledge of buildings, the patterns here are really, really clear. And if you look deeper into the data of outbreaks, again, it starts to point the finger. So for example, in Ireland, 2/3 of all outbreaks in workplaces are actually in these meat and fish and poultry plants. So that's fewer than 150 buildings in the entire country account for 2/3 of all workplace outbreaks. If we look at the nursing homes, the population in nursing homes is about 0.5% of the Irish population, and they've had 50% of the fatalities from COVID. So again, fewer than 600 buildings, less than 0.5% of the population, 50% of fatalities. Clearly there's something going on environmentally in these buildings. And it's repeated across in as well, where there's data collected on overcrowded housing conditions. The average outbreak is 13 in some places, whereas in normal, in more typical family homes that are less overcrowded and less densely occupied, it may be 2 in an outbreak. So when we join all of that together, I think it becomes quite obvious that it's the super spread that's spreading the pandemic. It's the environmental conditions in certain buildings that is giving us the high rates of cases. And the cases are leading obviously to hospitalizations and fatalities. I think it's been missed because we're looking at the wrong data and maybe we're collecting the wrong data. So whereas the virus is a biomedical crisis, the actual making of a pandemic is an environmental crisis. And what I mean by that is that the virus clearly has a biomedical origin and it needs a treatment. But the spreading of it and the exponential growth of it is entirely environmental. And I think we can see that from a lot of the data. And I would go so far as to say, having looked at a lot of the super spread events, I would say that the origins of them as aerosol and ventilation issues could plausibly be explained in the majority of cases to do with a number of factors: the outdoor and indoor air conditions in that climate, in that region at the time, and the likely response, a human response of how that building is operated, both for the comfort of the people in it and for environmental efficiency of the building. So when you look at those range of factors together, how we build in that climate, what the weather's like at the time, how we ventilate in those conditions, and how people use the building in those conditions, we can look at a very clear picture targeting how to prevent super spread. I would say in relation to that, that obviously buildings are regulated differently everywhere. So these are all factors that come into it as well. So coming from that, we can see that COVID is not spread by averages, and indeed comments about halving your contacts, I suppose it's a little bit like saying half the mileage you do on your car, when in fact the real issue is that we have dangerous intersections. We have places where all the accidents and all the contacts are happening. And that is why the spread of this disease is difficult to contain with very generalized public health advice, and a lot of which is not really scientific. Rules of thumb are not really helpful in this situation. It needs a very targeted response. And I suppose I won't get into K numbers and R numbers. There are people here who are better able to do that than me. But I would say that Professor Hugh Pennington in Aberdeen has made the point that in care homes, the R number, the reproduction rate may be above 10, whereas in the community, it may generally be below 1. Now, if we're looking to get our national rate below 1, the place to do that is to target the high R buildings. And we know where they are now. And Dr. Christian Drosten, who's sometimes called Germany's Dr. Fauci, has also said that the only way to stop the pandemic is to stop the super spread, and Germany are taking that very seriously. In fact, they're going to spend 500 million on improving indoor air quality in their schools and public buildings. When we look at that data, then we can see that mathematically it may be possible to suppress a pandemic by removing the sort of petri dish conditions that we have in certain buildings, and there aren't that many of them, and by mitigating the risk in other buildings where people spend time. And there's lots of ways we can do that. One of the other things that I think has been really interesting to plot across this is where the spring wave was. And there's research from China that has looked at this. It's very specifically across certain environmental conditions. We can see them in that yellow band along the top there, which is the northern states of the US. And we know there's been very serious hotspots in places like Seattle and New York in the spring. Across Europe, Madrid, Paris, UK, Ireland, Germany, Northern Italy, very particularly hit, Iran, and across into China and Wuhan. Again, that wave, that yellow band of those certain climate conditions is in the region of 30 to 50 degrees latitude. Ireland is slightly north of that, but as you know, we have the North Atlantic drift that warms our climate slightly. The region they plotted is around 30 to 50 degrees latitude, where conditions were 5 to 11 degrees outdoors with low absolute humidity. I think what's interesting is that over the summer, as that band of conditions moved north, obviously as we warmed up in the northern hemisphere summer, that yellow band tipped into Australia, and the worst hit area in Australia was in Victoria and the city of Melbourne, which would have been in similar conditions during the southern hemisphere winter. And now here we are in the autumn again, the same band across the same regions, but notably not so in Asia, where different precautions are being taken. What's also interesting is that in lab conditions, the half-life of the virus in and around those particular conditions is considerably longer than it is in summer months as well. So the seasonal pattern, again, I think pretty evident. This is Europe. Yes, we had the spring wave, we had the summer where there was a lot fewer restrictions and a lot lower growth. And then very predictably, when we came into the autumn, a very similar alignment across those European countries that have a similar temperate climate and a similar trend. And again, very interestingly, if you look globally or nationally across the US, it's hard to see a pattern. But when you pick out the northern states, and I've just picked out 5 or 6 of them here in USA, you'll see a very similar summer pattern that we've had in Europe, which is low caseloads and again rising very quickly in the autumn. And when you look at the southern states in America, you see very high in the summer when they're in their air conditioning zone. And again, that pattern of high caseloads in hotter climates in westernized countries that have a lot of air-conditioned buildings. Again, you can see that in other parts of the world, even in places like Iran and Iraq and in the Middle East across the summer, where they have very hot weather and they use a lot of air conditioning, which is recirculating indoor air. You have these summer peaks. So there are patterns that are very evident. So as I said, outdoor conditions around 10 degrees 70, which is what it has been in Ireland recently, which might seem 70% relative humidity might seem high, but that is relative to the temperature, and that is a low absolute humidity. But more importantly, when that 10-degree air is brought indoors and warmed to 20 degrees, as say in a nursing home, the relative humidity in that air that's warmed goes down below 40%, which starts to make very dry conditions. And if the outdoor air is down around 0, that relative humidity indoors could be down around 25% relative humidity, which is drier than the Sahara. When you put these factors together, and we see that our nursing homes a lot of them are in converted buildings. A lot of them are preventing drafts and overheating the indoor climate and not airing rooms consistently. They don't also have the factors of regular showering and cooking going on that's putting moisture into the air that we have in homes. You can see why the nursing home conditions are specifically identifiable as high risk and how easily that could be prevented with the right strategies of both airing rooms, filtration, monitoring and preventing the indoor conditions of high risk. So how do we prevent this? It is somewhat straightforward in a temperate climate. We don't have a country where we have a huge number of mechanically ventilated buildings. Most of our buildings are what we call naturally ventilated. They're ventilated by windows and wall vents. How do we do that? We need to obviously air rooms better. In the short term, that means being a bit cold. It also means reducing the occupancy, because the fewer people who are breathing out, the less likely it is that you will have a high concentration building up, even if you are ventilating the room. So spacing people apart from each other, reducing occupancy and airing is very important. We need really specific targeted public health information so that people understand how this virus is being transmitted, and then they can instinctively make smarter choices, like meeting outdoors, like keeping a window open, like wearing masks, like investing in filtration. We also need regulation and enforcement, and that can be done by monitoring, which is CO2 monitoring as a proxy for how fresh the air is. We need some knowledge as well about humidity and humidity control in particular buildings, and in some cases we will need to do re-engineering. In the longer term, we have to do this anyway. We have committed to near zero energy building standards, which means airtight buildings in relation to energy loss and wasting energy by overheating buildings and then letting the heat out the windows. We will be putting mechanical heat recovery units in all buildings. They work. They're a very low tech system of preheating, fresh air being drawn in all the time, air moving all the time, but that air being heated by the air that's been taken out of the building so that it doesn't come in as a draft. This is all relatively low tech, relatively inexpensive, and we will have to do it anyway to meet our energy and climate targets. So a little bit of the history. None of this is new. I think we have forgotten in our institutional memory and our regulatory memory how Spanish flu was tackled and may even have been defeated. ventilation and fresh air was a huge part of that strategy, both in Spanish flu and in Ireland when they tackled tuberculosis. I think the arrival maybe of antibiotics maybe medicalized some of this when there had been an environmental response of prevention to airborne illnesses. And then we had the oil crisis, and then we've had climate change with sealing buildings, all of which have moved us towards these sort of petri dish conditions in very particular places where people are sharing air and sharing virus. And we could very easily go back, I think, to some of the learning from before. Outdoor school was standard. A lot of social activity moved outdoors in Spanish flu. We know in Ireland our TB hospitals had outdoor verandas where people slept at night. And even the housing that was built in Dublin in the 1940s, people will be familiar with some of the blocks built in Dublin in the 1930s and 40s, like the Sims blocks. Those apartments were all built with balconies. In public housing, they were built with balconies large enough for a single bed so that a TB patient could sleep outdoors. So architecture has always been a really important part of the response, both in the design of the building, but also in the design of the ventilation of the building. And perhaps where we've gone wrong is that we've over-engineered or under-designed our buildings, and we very particularly have under-regulated our buildings, so that even if they were right in the beginning, there's no monitoring of how systems are operating, or maybe no good advice to people about how they need to operate even their own homes in a situation we have now in the context of having more airtight buildings. So where all of that leads me, and I would love to see more engagement across the different disciplines, and I would really hope that it is the convergence and the consensus in science that moves us all forward. And I would hope that this presentation will bring a lot of other disciplines to say that chimes with what I know, or that matches with what we know in my discipline. And I think it would be great now if the people who are modeling the epidemiology of this could start to micro model some of this, rather than doing global statistics or national statistics or across different counties. And the patterns here across buildings are what is really, really important. We don't have enough data, but the data that we do have is very much pointing towards a solution to this, and an engineered solution of reducing or even suppressing the pandemic by eliminating the high risk conditions where we are having super spread, and taking out the locations where dozens of people can be infected in a short space of a number of hours, and taking out the conditions where one family member is transmitting it to the rest of the family members within, again, a very short space of time. We can eliminate those conditions with public health information and some good advice and a modest amount of engineering. Thank you.
That's great. Thanks a million, Orla. And I think we can all agree that it's the point of convergence, I think, is where we need to be, and bringing all those strands of those expertise, but also the sectoral knowledge as well, in terms of what people are experiencing on the ground as well, to feed into that in terms of policy making going forward as well. What I might do now is I might just move to the question and answer area. We've had a number of really interesting questions coming in. I might just kick off actually just with one before I go scrolling through all the questions. We invited members of the INTO and the ASTI to attend the webinar today, because schools, of course, have been on the front line in a lot of this, and questions about architecture design and also aerosol transmission have been to the fore. I know both of you have had some experience of that. Maybe I might go back to you, John, and then move to Orla then about your thoughts on schools and aerosol transmission of the virus.
At present, schools are probably one of the highest risk environments that society has, because there's 20 to 30 people in a room all day long. So the time spent indoors is quite high. I mean, luckily our secondary school students have masks on, so you are minimizing the source in some ways. Ventilation, we know that classrooms have windows open a lot, doors and windows open, and students are freezing. My own children are in that environment already. But I think that some of the housing stock in schools is just not very good quality. And in the end, the teachers aren't really best equipped to deal with a balance between warmth and ventilation. And one of the things that Orla mentioned there was to use a CO2 monitor just to check ventilation rates. So we've been advising that. Now, of course, there's you have to fork out a few €100 for a CO2 monitor. And I have been in touch, some teachers have been in touch with me, and they've told me that they've actually installed ventilation systems or fans in their schools. Some principals have done that. So obviously there are some buildings that are just very poorly ventilated, and the only way to do that was to install ventilation systems at a substantial cost. And there's no support really, I think, from the Department of Education. I think that really is important to say that the advice that has been given to the teachers and the principals isn't been good enough, and the level of support has been poor as well.
Okay, thanks very much, John. Orla, I'll ask you to respond to that.
I would just comment on that. I mean, there's a lot of talk about how we interpret data. I think nothing has been said about the fact that education is and schools is the only sector that took the initiative on ventilation last August. People are sitting cold in schools because teachers did their own research and they took the initiative to prevent dangerous indoor air conditions. And in fact, I think the schools would have been in a much more difficult situation by now in terms of cases if that hadn't happened. So we need to learn from the fact that the teachers and schools and boards of management and maybe their physics teachers and their unions as well took the initiative on that and have prevented things being an awful lot worse. Whatever about people managing through September and October with windows open, it's not really tenable at this time of the year. Unless you decide it is outdoor school and you abandon uniforms and you organise the day around activity so that people are not miserable and uncomfortable in drafts, so that they're active and busy and that the timetable is organised in that way. Maybe by emptying classrooms every 45 minutes or an hour and giving them a good airing out or whatever. In the longer term, as I said, schools will have to do this in a structured way with monitoring, with proper ventilation. And I think we have to get through the next month. But in the short term, I think we need the Department of Education to take a very targeted strategy. Just myself looking at that school in Cork that's had to close, that was in a converted hotel. Just as an architect looking at that, immediately I would have concerns about ventilation. It was a converted hotel with small windows, low ceilings, and likely very little cross ventilation because of the hotel corridors. One photograph would tell somebody with architectural engineering experience that would have to be targeted first. And I would imagine around the country it is exactly the same. People need an expert eye on these buildings so that the ones that are most at risk can be done first, and that we can work backwards maybe to the places with high ceilings and outdoor circulation and fewer issues. But public health information here and technical information that goes beyond improve your ventilation is really important.
I suppose it brings back the point as well of the importance of having boots on the ground and actually, geographically and regionally specific teams that can go in and advise relative to obviously the buildings in question and obviously the environmental context as well. Just a related question that came up on the Q&A as well from Thomas McLaughlin. He said, I heard a restaurant owner saying on RTE over the weekend that it will be safe to eat in her restaurant as she has air conditioning in the restaurant. However, without HEPA filters, the air conditioning is more likely to spread the virus. Would that be fair to say? And I doubt there are many restaurants that have HEPA filters in their systems. So I suppose the questions about schools is also related to coming into the question about the hospitality industry and the role of ventilation and aerosol spread with that. Orla, I might start with you and then go back to John.
Yeah, I think terminology is really important here. What some people think of, a lot of people think air conditioning is bringing in fresh air, but a lot of the units that you will see in shops and restaurants and hairdressers are these wall-mounted units and ceiling-mounted units. They're in fact just reducing the humidity and chilling the air. They're not bringing in any fresh air. And one of those units was connected to spreading the virus across a room in an outbreak in a restaurant in Hong Kong, well beyond 2 meters. So I think for hospitality, I have to say the guidance that's been issued is totally inadequate. And with the best of intentions, a lot of restaurant owners may be reopening having complied with that guidance without an awareness that it is inadequate and it misses the most critical risk, which is airborne spread to their staff and their customers at long range and in short timescales. They're going on the evidence of one prison infection in America, and it was tracked with CCTV. Somebody was infected in less than 5 minutes in really bad air conditions. In meat plant in Germany, somebody was infected beyond 8 meters. again in bad air conditions. This information has not got out to the hospitality sector, and people unknowingly maybe will be having staff in break rooms, in storerooms, in cold rooms, in corridors and toilets, again, where the room might be ventilated, but these secondary areas aren't.
Okay, very good. Thanks, Orla. John, any comment on that?
Nothing to add really, other than we need to take in air from the outside as much as possible, 100% if possible, and if there is any air conditioning systems, need to be filtered very highly, as the questioner said there, with HEPA filters. Can do that, but again, I think you need to really look at the situation. Every different environment, indoor environment, is different, and if possible, you need to measure the ventilation rate as well.
Okay. We also have another just observation from somebody who works in a voluntary capacity in a care home, and they struggle to get the ventilation right with the senior population, weeping ventilation in place at the moment, and they have prohibited visits and persons leaving as well. So I suppose that's an on the ground, I suppose, report as to how difficult it is to manage that.
I personally, I think it would be better if care homes and nursing homes and even hospitals took a view that, you know, we hear people saying somebody brought it in. If they took the view that it has been brought in likely all the time, it's possible it was being brought in all summer with visitors and staff. But it's preventing conditions that then allow that to be transmitted is what's key. Break the chain.
We just have an earlier question, which is maybe more technical side, so I might go to you, John, for this one. Does aerial size change when the aerosol particles are arising from infected mucosa?
Okay, so I'm not especially well qualified, but as far as I know, there are 3 different sources of the droplets that become aerosols. The particles, I should call them really. See, even I'm calling them particles, aerosols, droplets. The terminology is quite confusing. The particles that are generated from the lungs are the smallest ones. They're typically centered. So we had those 2 big curves, and the smaller size curve, around about 1 to 2 microns. They're really from the lungs. The particles going up to about 10 microns from vocal cords. So that's in the in the windpipe and so on. And then the larger particles, the second hump that goes up to 100 or 200 microns, they're from the mouth. And so there are 3 main modes of particle types that are emitted there. So in the end, we cover a whole broad size range of particles. And yeah, that's as far as I know, I'm afraid.
Okay, and just with a related question then, somebody's asking about masks. How well do masks filter very small particles? The air has to go somewhere with movement possible along the boundary layers. So I suppose this is the which mask is the best one question.
Okay, so there's been a fair bit of confusion about this. It didn't start off well by the WHO. Say that masks weren't necessary, then they changed their mind, and it's a very big issue in the USA. It's become politicized, and there's a lot of misinformation spreading around. But the bottom line is that masks work. They work in 2 ways. They work in filtering the aerosol that you emit, but also any incoming aerosol from other infected people that might be in the air. So there's a 2-way benefit for that. And even surgical masks are deemed to be about 70 or 80% efficient. And we're really talking about the aerosol size around about 2 or 3 microns is believed to be the key size here. That might be the most. It's the peak of that first emission mode. People sometimes think of the naked virus, which doesn't really exist like that, and they're very efficient. So I think the masks do work. The key thing is the fit, to wear them properly, obviously over the nose as well as the mouth, plus also to make sure that there's a very quite nice fit around the face. Otherwise, the air can leak out very easily through the sides, or sometimes through the top. You know, if you have glasses, you might have experienced that already. And so the fit is really important with masks.
I would add to that, not talking about the chemistry of masks and particles, but it is very evident across the buildings where the outbreaks are that they are buildings where masks are not being worn. You know, the data is really clear on that. There's also some really good research came out of Germany where they ran a concert in the summer for more than 1,000 people as a live event, and ran various combinations of good ventilation, mask wearing and not. And that clearly demonstrates that if you sort out the indoor air quality in buildings with good ventilation, you can have a safe event for more than 1,000 people. And I think it's also notable that we've had a lot of outbreaks in meat plants in this country. We haven't had outbreaks in clean rooms where they're in the pharma plants where they're making medical devices and computer chips. So we just have allowed a situation to develop where we have a lot of unhealthy indoor air in certain buildings. All of that can be resolved, but the mask wearing is evident across all of these. They're places where masks are not being worn.
Actually, in relation to that, Orla, a few questions have come in about the spread or non-spread in dental practices. That's something that we had talked about a little bit before we started the webinar. So is there anything you'd like to say about that, Orla? And then I'll move to John.
Well, I think it's to do with the convergences of the sciences. Again, a number of dentists have contacted me to say, we know this stuff, we know about aerosols and prevention of aerosol transmission, as has somebody who works in a computer chip manufacturing in clean rooms, as has somebody else in the veterinary world who knows about ventilation of sheds for prevention of spread of airborne disease in animals. You know, this is, there's a convergence here of an understanding in lots of different disciplines. We just need to open up and have much broader conversations, I think.
John, have you any comments on that?
Just on the dentistry side, we actually did some work with Cork Dental School, and we did some measurements during various aerosol generating procedures, including polishing and drilling and so on, and that the very localized suction that is used works very, very well. We found that, okay? The only time that it didn't work very well was when it was moved within the mouth a little bit. We tested on mannequins actually, okay? But it does seem to work exceptionally well. I think that any dental office should just supplement, if they can, with HEPA filters in the room environment, I think, just to make sure. But obviously the dentists are well versed at wearing very high quality PPE, and that's the most important thing.
Okay. Two other kind of related questions as well. Can you tell us any more about the role of UV lamps in the possibility of combating the virus? And second one is, again, back to the AC units question. Do split AC units or fan coils which circulate the air within a room have an impact duration that on which aerosols remain in the air? So maybe the first one on UV lamps. We don't need to be like Donald Trump now and shine it on the inside and shine it on the outside.
UV lamps can work quite well in places where there's not the possibility of natural ventilation or mechanical ventilation. And I think that we know that the UV light can destroy the virus quite well. In certain environments, you can get the equivalent of something like 15 air changes per hour, which means that basically instead of filtering the virus, you kill it, shall we say, and it works very well. I think, again, what we're talking about is there's a range of possible solutions, and it really depends upon the exact environment that you're in. UV can work. You just need to make sure that is right for your environment.
Okay, thank you. Orla, would you like to tackle that one, or the AC units?
Yeah, I mean, any unit that is chilling the air and dehumidifying it and sending it around again is making the situation worse. It might be better in terms of comfort, you know, that it's not overheating, it doesn't feel stuffy in a shop. But if it's chilling the air and it's drying the air and it's moving it around further, it's actually making things worse. We need to be working towards outdoor or closer to outdoor conditions. If we all lived outdoors, we would not have a pandemic. It doesn't reproduce enough in outdoor air for us to have a pandemic.
More pressing questions at mind are coming up now, of course, the season that's in it and moving out of level 5, I think, tomorrow. So a very important question is about what Christmas and people mingling at home. Any suggestions of what people can do? And what I'll do is I'll just take one or two more questions and we'll be wrapping up shortly then. Orla, any suggestions for Christmas for people?
Well,
and John?
I think John and myself are going to be on Claire Byrne tomorrow morning on the radio answering some of these questions as well. I think first off is if you meet people outside, go for a walk, keep 2 meters away from them and spend as much time together as you want. Dress warmly. If you are meeting people at home, I think people need to think about it like cigarette smoke, and to think that it's not just about having a window open, it's having air moving. So if you have the window in your kitchen cracked open while you're meeting people, keep the door to the hall open as well, or run your kitchen extract fan all the time, run your bathroom extract fan all the time. It'll keep the air moving in a house. If you're meeting people and doing that, keep your mask on unless you're eating. Sit well apart or in different rooms when you're eating. Get air filtration fans, don't share bedrooms. keep secondary areas like bathrooms and hallways also keep the air moving, even with a fan. Lots of practical considerations, but I think if people understood better the main modes of transmission, we might be more focused on prevention, and people would start making much smarter decisions. I think, in fact, even the people who were drinking on the streets and things recently were probably making a much smarter choice than people who are meeting people at home. So we need safe outdoor places for people to meet, whether it's markets or venues or outdoor dining. We don't live in the frozen north. We can dress warmly and we can socialize well this Christmas in safe air.
Okay, John?
I think Orla said everything there. I wouldn't really want to add anything. I think she covered all the bases. The only thing really is that we still have, although we think it's a minor route, surfaces, so not to share utensils, cutlery, glasses, and so on. There is weak evidence to suggest that the surface and the fomites play a role, but we just don't know exactly at the end, of all of this. We still don't know. We can't quantify each of the transmission routes as such. So that's just an extra precaution.
Okay, I think we should all have a COVID elf on the shelf, I think, in everyone's sitting rooms this Christmas, and saying, stay away, don't pass the gravy boat, all of those kinds of things. But I think it's obviously a lot more nuanced, and we obviously need to be cognizant of all of these issues as well. I'll just wrap up now in a moment, but just to say thank you to John and to Orla for your time and expertise today. The comments have been flooding in, both by email and on the Q&A button as well on Zoom. And also to say that why aren't these people advising the government? And so they want to hear more, I suppose, of you, but I'm delighted to hear you'll be on the Claire Byrne show tomorrow. So very best of luck with that. I just want to say thank you to all our participants and those of you that have been Zooming in and listening in as well. We hope this has been of some help, and also it has been enlightening for many of us, I think, in terms of understanding the history as to the reasons why there was maybe a reluctance initially to engage with the science of it, but then also the continuous debates that are going on as to how best to prevent the modes of transmission as well. I think it's a point that we need to keep making in terms of getting that public message out there for many people as well. So with that in mind, this is a recorded session, so many of you may have friends or family or colleagues that were not able to Zoom in today. This will go up on the ISAG website, which is isagcovid19.org. You'll be able to access it afterwards. We'll also tweet it out, so do feel free to spread the word for those that might be interested in either contacting us afterwards or maybe even Orla and John as well. So just want to say thank you very much to both of you, and also to thank David Kelly and Dan Carey at the Moore Institute NUI Galway for facilitating this today, and Sinead Fuelon and others as well at ISAG as well. So wishing you all a very happy Christmas and all the very best from tomorrow on. And we will be back in touch with everybody with our next webinar that will be announced shortly on the website as well. So thank you all very much. Take care.
Thanks, everyone.
Thank you.